Hello, my name is Jack Dierckes, and I am a PGY1 pharmacy resident at Wake Forest Baptist Health. And today I will be presenting the results of my ongoing research looking at the survival and safety outcomes of R-CHOP-based regimens in elderly patients with diffuse large B-cell lymphoma. Neither I nor any of my advisors have any disclosures. For some quick background, non-Hodgkin's lymphoma is one of the most common cancer types in the United States, with diffuse large B-cell lymphoma being one of the most common subtypes at around 32.5% of cases. Standard of care includes the R-CHOP regimen, which includes rituximab in combination with cyclophosphamide, doxorubicin, vincristine, and prednisone. This regimen is predominantly studied in patients less than 60 years of age. A dose-attenuated version of this regimen, called R-miniCHOP, is preferred in elderly and unfit patients due to better tolerability and has primarily been studied in patients greater than 80 years of age. As the average age of diagnosis has increased, data in older populations has not also increased. With no current studies being conducted assessing tolerability of R-CHOP or R-miniCHOP in elderly patients greater than 70 years of age, we hope to contribute to the data in this patient population. The objectives of our study were twofold. First, our primary objective was to assess the outcomes and tolerability of R-CHOP or R-miniCHOP in patients 70 years of age or older with DLBCL, with our secondary objective assessing what disease and patient characteristics prompted the choice of treatment regimen. To assess this, we conducted a single-center retrospective cohort study. Patients were included if they were 70 years of age or older, diagnosed with de novo DLBCL, with a treatment plan for an R-CHOP regimen. Notable exclusions included receipt of more than one cycle of chemotherapy prior to R-CHOP, or those with double hit or triple hit status. Our primary endpoint was overall survival in months. This was defined as the time from date of first cycle to date of death or last documentation if alive. Secondary endpoints included overall survival at 2 years, overall response rate defined as the percentage of patients with complete or partial response to treatment, progression-free survival, progression to second-line therapy, and safety and tolerability endpoints including dose adjustments, hospitalizations, transfusions, documented adverse events, and changes to supportive care regimens. For our statistical analysis, we utilized Kruskal-Wallis tests for our continuous data, chi-square tests for our categorical data, and for our time-to-event analyses, we utilized Kaplan-Meier curves for survival estimation, with log-rank tests for statistical comparison between groups. After screening through our inclusion criteria, 117 eligible patients were identified based on their age, diagnosis, and treatment through an EMR-generated report, of which 54 patients were excluded, with the most common reason for exclusion being prior or alternative chemotherapy. After screening through our exclusion criteria, 63 patients were identified and included in our final analysis, of which 48 patients received R-CHOP, while 15 received R-miniCHOP. Patient demographics are noted above, where we found patients who received R-miniCHOP were significantly older than those who received R-CHOP, with a median age of 83 versus 75 respectively. We also found significantly more patients over the age of 80 in the mini-CHOP group at 73.3% versus 18.8%. Although the ECOG performance status of the mini-CHOP group trended larger than that of the R-CHOP group, it was not statistically significant. No significant differences were found between groups for comorbidities, although mini-CHOP recipients trended towards more comorbidities, especially with cardiac disease. Patients were well distributed across stages, with stage 4 being the most common stage in both groups. Patients in the R-miniCHOP group trended towards higher International Prognostic Index scores, however no statistically significant differences were found. Only a small proportion of patients were found to be EBV positive, with only 6.3% in the R-CHOP group. For our primary outcome of overall survival, we performed Kaplan-Meier estimates. Longer overall survival was found in the R-CHOP group at 76.6 months versus 21.7 months in the R-miniCHOP group. However, this difference was not statistically significant, likely secondary to low numbers of patients. Similar to overall survival, progression-free survival was substantially longer in the R-CHOP group at 47.4 months compared to 14.4 months in the R-miniCHOP group. But this too lacks statistically significant difference. Treatment response was comparable between groups, with the majority of patients having a complete response to treatment. We also found a comparable overall response rate between groups at around 80%. Due to the short enrollment window, a 2-year overall survival outcomes are still undergoing investigation. Statistical analysis of our safety and tolerability endpoints is still ongoing. However, through preliminary analysis, we have found that around 50% of patients in both groups were hospitalized at some point during treatment for a treatment-related adverse event, with febrile neutropenia being the most common identified cause for hospitalization. Common other causes for hospitalization included overall weakness, dehydration with and without diarrhea, and syncope. Dose adjustments were found to be more common in the R-CHOP group at 43.8% versus 33.3% with the R-mini-CHOP group. Of the analyzed reasons for dose adjustments, cytopenias and febrile neutropenia were the most common reason for adjustment. Many patients received changes to their supportive care regimen, whereas roughly comparable between groups. Some limitations of our study include that most of our data collection points relied on accurate documentation within the electronic medical record. Additionally, many of our outcomes vary based on provider discretion, including treatment allocation, dose adjustments, and hospital admission. However, we did use this to our advantage to assess what patient and disease characteristics played into treatment allocation. The sample size for our R-mini-CHOP group reduced the power of our analysis and made statistical comparison difficult between groups. We also chose not to have a minimum follow-up duration for our study and included patients who started treatment in 2020. This meant that only a small percentage of patients were able to be assessed at 2 years follow-up and limited our analysis of that endpoint. It additionally led to more censoring in our Kaplan-Meier analyses. From this data, we concluded that although median overall survival and progression-free survival were roughly 3.5 times longer in the R-CHOP group compared to the R-mini-CHOP group, this difference was not found to be statistically significant. These analyses were also greatly limited due to our low patient numbers. Rates of adverse events were similar between treatment groups, showing the balance between treatment allocation and patient and disease factors. Finally, across patient and disease characteristics, age was the only significant predictor of treatment allocation. And finally, for my self-assessment question and answer, is there a statistically significant difference in overall survival between R-CHOP and R-mini-CHOP in elderly patients greater than 70 years of age with DLBCL? Although median overall survival was 3.5 times longer in the R-CHOP group compared to R-mini-CHOP, this difference was found to not be statistically significant, likely secondary to low patient numbers. And with that, I will conclude this presentation. I appreciate your time and look forward to answering any questions.